for me to be here in Manchester for this presentation, and I know, of course, that I'm not honored by the ESTS, and on behalf of the ESTS, I'm very grateful to the British Society for this invitation too. This is a rather difficult topic for a surgeon because, well, I don't want to be remembered as the guy who came to Manchester to say that N2 disease is not for surgeons. But this is the role I'm representing today here, and I found some evidences based on my own practice and on the literature to defend this position. N2 disease precludes surgery, and I believe this can be true. As a summary, I'm first focusing the problem, and then I'm adding some reasons to you on why not to operate on clinical N2 disease. Talking about focusing the problem, I'm first presenting some reasons, some evidences about that a simple image is not enough to classify a patient as a clinical N2 disease, and that if you rely on images and you're sending patients for induction therapy simply based on images, probably you're treating N0 patients and stating that chemo induction plus surgery is very effective in N2 patients, but they are not N2, they are N0 cases. The second topic I'm briefly addressing to you today is that intraoperative finding of N2 is not comparable to preoperative diagnosis of N2. Both diseases have different prognosis, so you can't include this subset of patients when you analyze your survival treating N2 patients. The second point of my talk is some reasons to avoid surgery on N2 patients. The first one is that there is no survival advantage for the patient. And the second one is that this is not a risk-effective therapy. I'm showing to you that mortality is high in some cases of N2 resection. And this is a good reason to avoid surgery in these cases. So let's start in the beginning. Sometimes we classify clinical N2 patients simply because they have enlarged lymph nodes in the mediastinum, right? The specificity of CT scan for N2 disease is, in the best of the situations, 80%. The meaning of that is that you have the risk of wrongly classifying 20% of your cases as N2, clinical N2 cases, if you rely on the size. Especially in the area where I'm working, many patients were minors in the 70s, and they have very enlarged lymph nodes in the mediastinum and both hilum. So these patients can have CT scan positive, even PET scan positive, but they are N0. What about PET scan? This is a very nice meta-analysis on the reliability of PET scan for correctly classifying N2 disease, and you see that pool specificity is 88%. It's a little bit better because if it depends on the cutoff point. In my hospital, for instance, 2.5 is not enough to classify a patient as N2 because of high sensitivity of the new machine. We need 3 and some, 3.5 or something like that. It depends on the sensitivity of your scan, of your PET scan. But in this meta-analysis, the top specificity is 88%. That is 18% of false positives in your series, probably. What about integrated PET and CT scan? This is, again, a very nice meta-analysis. And in stage 1B, the negative predictive value is 89%, still a little bit better than PET scan only, much better than CT scan, but still, this is the story of the glass half empty or half full of water. Maybe for you, 11% of false positive is acceptable, but maybe not for the patients. Let's focus on invasive mediastinal staging. This randomized clinical trial was published at the Journal of the American Medical Association in 2010. It comes from the Netherlands, and in this paper you can see, or from Belgium maybe, I apologize if this is coming from Belgium, I don't remember it this time. From Belgium? From Benelux? It's okay. From Europe? Okay, no problem. In this arm, you see surgical staging, meaning mediastinoscopy. In this arm, you see endosonography plus surgical staging. Patients were randomized to receive only mediastinoscopy or EBUS and mediastinoscopy. The negative predictive value is 93%. This is the most important variable to look at when you're judging a diagnostic test for the mediastinum. Is not sensitivity nor specificity, because the reliability of the test depends on the prevalence of the disease. In mediastinal staging, you can reach 93% according to this randomized clinical trial. This is my personal experience. If you use mediastinoscopy with a prevalence of 0.64, negative predictive value is 0.87. With EBUS alone is 0.88, which is the same. But if you join together EBUS plus EUS with a prevalence of 0.50, the negative predictive value is 0.95, which is fairly acceptable. 5% of false negative in your series. So my first message is invasive clinical staging is required. If not, probably you're treating N0 cases. So let's move to what about intraoperative finding of invaded lymph nodes in the mediastinum? I'm simply quoting this paper coming from Robert Serfolio in Alabama. He analyzed survival in patients with unsuspected N2 disease after invasive mediastinal staging. And in his series, he found around 35% 5-year probability of survival, which is fair. It's okay for patients in N2 disease. This is completely different if you compare to clinical N2 patients, in which survival is around 0.20. The probability is 20% of survival at 5 years. So this subset of cases, in this subset of cases, you can expect much better survival. And this is true especially for patients with one single station. But this is not the topic we are dealing with. Today we are discussing if induction plus surgery is good for your patients, or if they should receive only chemo and radiotherapy. So my next messages are surgery for clinical, demonstrated, cytohistologically demonstrated N2 disease offer no survival advantage and is very risky for your patients. I'll do my best to convince you surgeons on these 2 points. There are 2 main randomized clinical trials published comparing induction therapy plus surgery or induction plus radical radiotherapy. This is one of them, published in 2007. As you can see here, there are no advantages for overall survival. So radiotherapy compares to surgery in terms of long-term survival. If you look at bilobectomy and pneumonectomy, median of 5-year overall survival for patients with pneumonectomy is 12%. So it is not worth indicating pneumonectomy after chemoinduction. And I'm commenting after that pneumonectomy is, the probability of pneumonectomy is much higher in N2 cases. This is the second randomized clinical trial published in Lancet in 2009. This is progression-free survival. If you have a look at these figures, at these images, this is the arm of radiotherapy, and this is the arm in blue of patients treated with chemo, radio, induction plus surgery. So progression-free is acceptable for patients after resection, but this is not the figure patients are looking for. Patients are not interested in progression-free. They are interested in long-term survival, and this is long-term survival. Both figures are exactly the same, after induction plus surgery or after induction plus radiotherapy. So no advantages for survival. Honestly, I have to say that these investigators found differences depending on the type of surgery. In overall survival, they found a better survival after lobectomy compared to radiotherapy, but these differences disappear after pneumonectomy. And in fact, expected survival after pneumonectomy was worst. So pneumonectomy is clearly not indicated after induction therapy. These figures come from my institution. These were 170, 100 whatever patients from my institution. And this is the rate of pneumonectomy, which is 3% after no induction. This is patients in clinical stage N0, but it was 13% in patients after induction. This is expected because these patients usually have more difficult or more invaded lymph nodes in the hilum. The late mortality after pneumonectomy has been published to be very, very high in patients after induction chemotherapy. If you rely on 30-day mortality, it could be acceptable. 7% is all right. 11 is a little bit higher, and 5 after left pneumonectomy. But look at these figures after 90 days. After pneumonectomy, 90-day mortality is 20% after induction and pneumonectomy. And this is why this figure comes from my institution too. And this is related to 350 or around pneumonectomies. You can see a decline in mortality after 2 months, but after 3 months, mortality increases due not to cancer, to pneumonia, cardiac infarct, arrhythmias, pulmonary embolism. So pneumonectomy is a very dangerous operation 3 months after surgery. So to conclude, if you if you're talking about the advantages of surgery for N2 patients, first, you have to demonstrate that these are real N2 patients by means of invasive staging, not PET-CT, not CT scan. Second, exclude from your series of cases intraoperative finding of N2 because these patients have a better prognosis. Third, and again, I'm suffering a little bit because I've been a surgeon. This is rather difficult to pronounce even in English. Surgery after, long-term survival after resection in N2 disease offer no survival advantages to patients, and this is a risky surgery, especially if you are obliged to do a pneumonectomy. Thank you very much for your attention, and now, next speaker.